I'm going to talk today about Staphylococcus aureus, specifically bloodstream infections and their complications. Staph aureus, Staph aureus bacteremia is a disease that carries a high rate of mortality, a high rate of morbidity, and a high rate of recurrence. It's the only specific bacterial bloodstream infection that we have evidence-based algorithms for how to evaluate and treat. And that is a consequence of its high risk of complications. And there's a few things that I'm not going to talk about today. I'm not going to talk about Staph aureus bacteremia in the pediatric population, although that is a big topic. And I'm also not going to talk really about treatment. It's outside of the scope of the points I wanted to make today, and that would be a separate discussion all in itself. I have three objectives here. What I'm aiming to get across today is the gravity of Staph aureus bacteremia, the pitfalls that you can fall in while you're evaluating a patient with Staph aureus bacteremia, and the tools that we're looking at to improve outcomes in those patients. So we often think of Staph aureus as the big bad wolf. It's looking for a way to blow your house down. It's a very in-your-face bacteria. So take furunculosis or purulent cellulitis. There's pus, there's erythema, there's pain, there's odor. Patients notice this, and doctors notice this. It can get really ugly. But that's not always the case. This is imaging of vertebral osteomyelitis, where most patients will have pain around 80 to 90%, but not everybody. And low back pain is a very common symptom in general. And so this might not come to your attention, or it might not come to the patient's attention during an evaluation for Staph aureus bacteremia. But an unidentified site of infection like vertebral osteomyelitis is a big risk factor for recurrence of Staph aureus bacteremia. So you can see that aside from being a big bad wolf, it's also like a boogeyman. It's a hiding in the shadows. And I don't want to get too cute here, but if you don't look in the shadows, you're going to miss it. And in my experience, patients who come back in with recurrence of Staph aureus bacteremia are more sick than they were the first time. So let's look at three cases of Staph aureus bacteremia. And these all are going to have different flavors to them. First case is a man presenting with hypotension from his dialysis clinic. He has a right hip joint that was replaced around 2 years ago. And his blood cultures on admission grew Staph aureus, methicillin susceptible Staph aureus, or MSSA, in 2 of 2 blood cultures, and then it cleared 2 days after appropriate therapy. I want you to look at this like you're being called about this patient. So this is case number 1. Case number 2 is a younger patient with HIV, a CD4 count of 74, who's getting admitted with methicillin-resistant Staph aureus bacteremia that has persisted for 4 days despite treatment with vancomycin, and a TTE is performed, which returns unremarkable. So that's patient number 2. And then case number 3 is a 64-year-old patient with diabetes, lumbar spine osteomyelitis, probably chronic back pain, who comes in with an acute worsening of their back pain, or maybe more subacute, and new lower extremity neurologic deficits. Blood cultures grow MSSA, and he's taken emergently to the OR because MRI imaging shows cord impingement. So that's case number 3. And I want you now to think about these cases. I was going to put sort of like a poll in here, but I was afraid it wasn't going to work. So I want you just to think about these cases and think about which one you'd feel more comfortable coming up with a treatment plan for. Case number 1 is a patient who you can guess probably has a central line infection related to a dialysis line. And it's a removable source, something you can take out. It seems easy, right? But the presence of that prosthetic hip joint complicates your management, raises the risk of recurrence. So it's not as simple as it might seem. Case number 2 is a patient with persistent bacteremia who's immunodeficient, and you don't know where it came from. And when you don't know where it came from, it's hard to know how to control that source. And then case number 3 is a patient with Staph aureus bacteremia who already has an identified complication. So you know that this patient has a metastatic focus of infection, that their Staph aureus has traveled to a distant location. You know that that spine is infected. You know that it's already caused disease in a distant site. It's already complicated. So case number 3 is a patient who you know has complicated bacteremia. And so it's each of these different cases highlights different difficulties in treating Staph aureus. 1 is risk factors of recurrence. 2 is unknown sources and unknown distant sites of infection. And 3 are the destructive distant sites that it can cause in general. So let's talk a little bit about Staph aureus, the bacteria in general. Basic things out of the way. We all know it's a sphere-shaped bacteria. It tends to live in a cluster configuration, and that's where the name Staphylococcus is derived. It makes these nice, large, golden-colored colonies in culture, and that's where Staph aureus gets my favorite nickname for it, the golden grapes of wrath. I actually just learned that one, so I can't take full credit, but I do like that name. It's also referred to as the king of pathogens. It's a bacteria that deserves our respect as physicians. It is inherently an opportunistic pathogen, and it's a typical flora in around 80% of patients at some site in the body. Around 30% of humans are colonized with Staph aureus in the nasal cavity. But we don't often think of it as opportunistic because it's so good at invading and causing infection. But we don't consider it, a canonical pathogen like, Mycobacterium tuberculosis or Yersinia pestis. It's present on the body and then it causes infection. Prior to the 1940s, Staph aureus infections were invariably deadly. Bacteremia, pneumonias. We didn't have a way to combat it. When penicillin came around, we had about 10 years of good treatment for Staph aureus. And then by the end of the decade, most strains of Staph aureus that cause clinical disease were resistant to penicillin. And so it's very rare now to find an isolate of Staph aureus that is susceptible to penicillin, but thankfully we have other agents that are now available. Infection usually occurs across multiple different organ systems. That's infection through contiguous invasion from a wound deeper into the site, through hematogenous spread. And then Staph aureus also, just because it has its own food poisoning situation, which is probably one of the least pleasant food poisoning situations to have if anyone has ever suffered from that. And vaccines have been created in hopes of targeting Staph aureus, but so far none have really been successful. So I want to move now and talk about a couple of virulence factors that make Staph aureus so good at causing infection. Number 1, I mentioned earlier that 30% of people will be colonized with Staph aureus in the nasal cavity. And organisms that colonize the nasal cavity are very good at spreading across distant parts of the body. Just think of how many times we touch our face and then touch other parts of our body. Staph aureus also colonizes the axilla and the groin, the nape of the neck, but the axilla and the groin usually not as readily available, covered with clothes. The nape of the neck we don't touch as much, but we're always touching our face. When we touch our face, we touch the rest of our body. We're moving Staph aureus from the nose to those areas. I found a couple articles I thought were interesting when I was researching this talk. I found one article that looked at how patients prefer different strains of Staph aureus in their nose. And so if you have a patient who is colonized with Staph aureus in the nose, you decolonize them, and then you re-challenge them with specific strains of Staph aureus. Most of the time, if you retest them after re-challenging, they will have selected for the prior Staph aureus that colonized their nose. So it seems to be a combination of Staph aureus that likes the patient and the patient that likes that specific strain of Staph aureus. But being colonized with Staph aureus in the nasal cavity is a significant risk factor for infection from Staph aureus. Number two is coagulase production. And you think back to how we categorize different Staphylococcus, coagulase negative Staphylococcus, which is a big group of bacteria, and then Staphylococcus aureus. Part of the innate response to bacterial invasion through the skin is formation of local thrombosis. So you cut off blood supplies, you try to impede progress of the bacteria into the bloodstream. Staph aureus can produce coagulase, which prevents that thrombosis and makes it easier for it to involve or to invade into the bloodstream and then disseminate to other sites. And once it enters the bloodstream, it typically travels to the liver first, and it will invade into macrophages in the liver, Kupffer cells. And those macrophages might destroy Staph aureus, or Staph aureus might be able to resist phagocytosis and just sit there in those cells. And if it can enter a monocyte that travels to another location, it can travel undetected to that site where that monocyte is going. And we refer to that as the Trojan horse phenomenon. So that's why I have a picture of a Trojan horse here. And once Staph aureus gets to that site, it then promotes coagulation, clot production, and endothelial injury, and that creates sort of a nest for it to sit in and cause a nidus for persistent infection. And so if Staph aureus reaches prosthetic material, like a prosthetic joint, central line, heart valve that's been replaced, it can create this mesh-like structure, which we refer to as biofilm. This is an electron micrograph of Staph aureus inside of a biofilm. There's a lot of bacteria in there. And in that biofilm, Staph aureus can resist antibiotics. It becomes metabolically inactive, and that makes it less detectable by the immune system. And it can sit there for a very long time and evade detection by the immune system and by the physician. In 2017, there were 120,000 patients diagnosed with Staph aureus bacteremia in the US. That number is probably a little bit higher, but this is from the CDC and the National Health Safety Network. 20,000 of those patients died as a direct consequence of Staph aureus bacteremia. So the mortality rate is anywhere between 20 to 30%, and that's been about stable over the last decade or so. The annual incidence of Staph aureus bacteremia in the US is probably about a quarter that of myocardial infarction. So it's not a small number. When we think about Staph aureus bacteremia, we categorize it as healthcare-associated or community-acquired disease. And that's because patients falling into those different categories have different risks of developing complication from their infection. Healthcare-associated infections include patients who developed infection in the hospital, so we're in the hospital for at least 48 hours and then develop bloodstream infection, or have a lot of healthcare exposure outside the hospital, whether they're in dialysis or they had a recent outpatient surgery. And then we have pure community-acquired infections, patients who had not had a lot of contact with healthcare, had not been recently admitted to the hospital, and are coming in with Staph aureus bacteremia. And those cases are more difficult. Patients with community-acquired bacteremia, on average, around 40% of the time will have a metastatic site of infection. On average, have about 3 times higher rates of endocarditis compared to patients with nosocomial infection. And more often, you'll have difficulty identifying the source of bacteremia in patients who come from the community. It's just not as obvious. They don't have the central lines. They don't have recent surgeries that you can look at. It's a little bit more difficult to pin down how they developed Staph aureus bacteremia. In community-acquired disease, another important point is that bacteremia is often present for longer periods. Patients don't come to care as quickly as if they're already hooked into healthcare network or they're already in the hospital. So patients may present with a week or two of fever as opposed to fever for one day and then sent right into the emergency room. So it's partially that patients are probably bacteremic for longer, which is why they're at higher rate of complication. But there are also more virulent strains of Staph aureus in the community compared to inside the hospital, such as the USA 300 strain, which makes up most cases of community-acquired Staph aureus infections. This is data also from the CDC and the National Health Safety Network. It's acquired from EHR review, including Cerner. The only cases that have really decreased in the past decade are MRSA bloodstream infections that are nosocomially acquired. And that's probably directly related to efforts to reduce rates of CLABSI, to reduce rates of surgical site infections, of which Staph aureus is the most common contributor. And I think there's data to support Staph aureus as the most common nosocomial bacteremia period, but we're doing better at bringing those rates down. But community onset disease has been stable, maybe slightly increasing. So maybe now that I've put some fear of Staph aureus into you, you might be wondering what puts your patient at risk for Staph aureus bacteremia. And this is a list of known risk factors, traditional ones that we often consider. Age probably fits in here as well, but it's not as strong as these risk factors that I've listed here. One that we're commonly asked about is, why is having a prosthetic device a risk factor for bacteremia? It's not that the device is infected and then we put it in and those patients become bacteremic because the device was already infected. It has to do with the process of bacteremia itself. Bacteremia is not a rare occurrence. Transient bacteremia from intermittent bacterial invasion happens from skin and soft tissue infections or infections elsewhere. But that probably goes unnoticed and is cleared by the immune system. But in a patient who has a device, it allows microseeding events when that bacteria gets to that device. And the microseeding events leads to bacterial replication at that site. And then it acts as a persistent nidus for continuous bacteremia. That's also the reason that we ask for blood cultures separated by about 20 minutes or so when we're looking for endocarditis, because we're looking for continuous bacteremia from a nidus inside of the bloodstream. And so it's not the device, placing the device itself, that's a risk factor for Staph aureus bacteremia, unless you have like a surgical site infection, but it's that altered flow of blood near that area where that prosthesis is, whether it's a central line or it's a heart valve or it's a prosthetic joint. I've used the term complicated infection a few times now, and sort of confusingly, the way we categorize infections as complicated is by ruling out that infections are uncomplicated. And these are 5 things I've listed here. This is from the IDSA guidelines on the treatment of methicillin-resistant Staph aureus. But these are the checklists that we've used to determine whether patients have a uncomplicated bacteremia or a complicated bacteremia. And the importance of determining between the two is it helps you figure out who is at high risk for complications and who is at high risk for recurrence. For Staph aureus bacteremia to be uncomplicated, you need to have excluded endocarditis. Your patient cannot have any indwelling devices. You must have cleared blood cultures or have negative blood cultures within 2 to 4 days of starting appropriate therapy and acquiring source control. Your patient should defervesce within 3 days, and you must not have any evidence of metastatic infection. If you meet those criteria, then we label that infection that bacteremia is uncomplicated. But if you meet any of those criteria, then you now have a complicated infection. Doesn't mean you have a metastatic site of infection somewhere, but your infection has just become more difficult to treat because your risk of metastatic infection, your risk of recurrence is higher. The reason that we need to identify complicated cases is so that we can prevent recurrence. We can prevent the morbidity and the mortality that's associated with Staph aureus bacteremia. And this is a chart that was recently published and looked at rates of recurrence of bacteremia after events of endocarditis separated by different organisms that caused it. So we have common ones like Streptococcus, Staphylococcus aureus, Enterococcus, and coag-negative staph. You would think that after a certain amount of certain amount of years go past, that your risk of recurrent bacteremia would level out. And that happens with the majority of organisms. But 5 years out from infective endocarditis with Staph aureus bacteremia, patients are still recurring. And it reaches a recurrence rate of 5 years of about 10 to 15%. A lot of caveats probably in this paper. Not all cases are relapses, some are reinfections, but there's something about Staph aureus that raises a patient's risk of bacteremia in the future much more than other bacteria. Yes.
And like people who had this, they were treated. So they would have been like bombed with antibiotics, theoretically cleared, and they're recurring later.
Right. Right. And so this paper, dealt with a lot of patients, thousands of patients. And so they didn't really go too deep into the details of treatment, but all patients that were included were treated for endocarditis. So it's possible that some were not treated as thoroughly as we would have hoped. And that's probably the case with Streptococcus, and probably this case with Enterococcus and coag-negative staph in this whole group of patients. But yeah, much higher rates of recurrence years out with Staph aureus. Okay, so let's move into some pitfalls that you can fall into when you're evaluating patients. And these are pitfalls that could eventually lead you or lead your patient into developing recurrence or experiencing complications. The first is failure to diagnose. The only test we have to diagnose Staph aureus bacteremia are blood cultures. There's data looking at using more rapid tests, PCR tests from direct blood samples, but the tests we use now are blood cultures through and through. And your test result is only as good as your test sample. With a blood culture bottle, you want to get at least 8 to 10 milliliters of blood, and that's in each bottle, the aerobic and the anaerobic bottle. But one set of blood cultures has a sensitivity about 87 to 90% for Staph aureus. It's lower for other bacteria, but Staph aureus' sensitivity is better because it is a rapidly growing bacteria. But if you just get one set of blood cultures, you're going to miss one out of every 10 cases of bacteremia. 2 sets, you raise your sensitivity better, 97 and around 93 to 97%. 3 sets in most studies found every case of Staph aureus bacteremia. But this is important in your initial workup. This is important in monitoring your patient through therapy. As patients are treated with antibiotics, bacterial load in the bloodstream gets smaller, and the sensitivity of your blood cultures probably gets lower. And so making sure you have the right volume, making sure you have the right amount is going to make sure that you're diagnosing Staph aureus bacteremia initially, and that you are correctly following for a resolution of bacteremia. So pitfall number 1 is failure to diagnose. Pitfall number 2 is failure to identify hidden sites of infection. And here I have pictures of vertebral osteomyelitis on the left and psoas abscesses on the right. Missing these infections, which can be protean in presentation, so they can have a lot of different symptoms that patients might complain about, but missing these infections missing a big vertebral osteomyelitis, missing a big psoas abscess, and if you treat for uncomplicated disease, they're invariably going to recur. They will recur potentially with epidural disease at that point, or invasion of the psoas abscess into bone or other sites. I mentioned before that 40% of patients with community-acquired Staph aureus bacteremia will present with a metastatic infection already in place, and these are what they are: 2 to 12% vertebral osteomyelitis, up to almost 10%, mostly chorioretinitis, 6 to 24% for endocarditis, but that true number is probably around 10 to 12%, and then pulmonary emboli. And so many of these sites are going to require either prolonged treatment or debridement. They're going to change your management. And when we're talking about hematogenous-based infections where bacteria has gotten to the bloodstream and caused that specific infection, Staph aureus is the #1 cause of all of these. And so these are the things that we are particularly looking for when we come by and we evaluate patients with Staph aureus bacteremia. Pitfall #3 is probably worrying too late about Staph aureus bacteremia. And what defines persistent or refractory Staph aureus bacteremia still sort of eludes us. If you take a poll of a lot of different physicians and ask them how many days of Staph aureus bacteremia would start to worry you that you're not doing something right, you would probably come up with different answers. But if you ask this group of doctors who researched mortality every day of bacteremia, they would tell you that 3 days of bacteremia is what separates patients who live and patients who die. Every day of bacteremia in this study that looked at about 500 patients with Staph aureus bacteremia, every day of bacteremia raised mortality by 16%. And so time sort of is very valuable when you're evaluating patients for Staph aureus bacteremia. You want to get them cleared as soon as you possibly can. At this point, I've kind of contradicted myself. I mentioned earlier that uncomplicated bacteremia includes having negative blood cultures at 2 to 4 days. And then now I've said that 3 days is a risky situation. I think eventually our definition of uncomplicated bacteremia is going to change. This is pretty new data that came out in 2021. The whole definition of complicated bacteremia is still probably in flux. The last pitfall is missing patients who have a risk for recurrence. Recurrence happens in about 10% of patients, and it's 50-50 relapse or recurrence of the same infection that patient had before, and then reinfection, which is a new bacterial strain causing new infection. But these are the big 4 risk factors for recurrence: being on dialysis, having foreign material placed, MRSA infection, and persistent bacteremia. So if your patient has these, it's someone who you want to pay attention to a little bit more after they finish treatment. So I want to move now and talk about the tools that we're working on to identify patients who actually have complications. We know what the risk is, but how do we know who actually has developed a complication from Staph aureus bacteremia? Sorry, I was supposed to be higher, but like I said, can't hit the high notes anymore. That's me tooting my own horn, tooting our own horn. But I'm going to do some real talk right now, and I hate talking about myself, but here it is. ID consultation, when we're involved in cases of Staph aureus bacteremia, outcomes are better. Consultation for Staph aureus bacteremia requires bedside consultation. There's even been studies looking at is having a consultant see a patient virtually as good as having a consultant see a patient at bedside. And for Staph aureus bacteremia, the answer is no. And it's probably not our pure presence that makes people better. Well, I like to think about it. But When we're consulted in patients with bacteremia, there is further and more thorough evaluation for metastatic disease. With consultation, the relapse rate is around 10%. Without it, it's about twice as much. And if you look at the patients who relapse, who did not have ID consultation, about half the time, that's because of failure to remove some type of foreign material. So central line wasn't removed. Wasn't considered that the prosthetic joint that was in there for 10 years could have been seeded by bacteremia. Or there's inappropriate choice of the agent used to treat bacteremia. So a patient who has a reported penicillin allergy is on vancomycin for methicillin-susceptible Staph aureus bacteremia. And so the benefit from ID consultation is present at the bedside, and it's during the treatment of bacteremia, but then it extends beyond treatment of bacteremia. And the benefit, 40, 60, 80 days out on mortality has to do with monitoring for recurrence. It has to do with monitoring for relapse, has to do with monitoring while on treatment. And so because of this, a lot of institutions require ID consultation when a patient is diagnosed with Staph aureus bacteremia. And so you will see on the micro reports, if a blood culture goes Staph aureus, we'll say down at the bottom that ID consultation is required. And this is why. There's good data to support. Okay, I'm going to move on from that. I considered including slides here on echocardiography, but I want to instead maybe focus on an emerging technology that we have to identify patients with complicated Staph aureus bacteremia, and that's PET-CT imaging. There's precedence for use of PET-CT in Staph aureus bacteremia. We use it in fever of unknown origin. It's included in European guidelines for prosthetic valve endocarditis. And the hope is that you find a site that's infected that you weren't previously considering before, or you use PET-CT to rule out that there are distant sites of infection, and your patient who is high risk for complicated disease, you've ruled out that they actually have it, and you could potentially use a shorter course of treatment. PET-CT is less invasive than transesophageal echocardiogram, but it gives you different information. Patients are more familiar with the idea of CT than they are with TEE, so it may be a more approachable tool to use as well. So on the left is a PET-CT image of a patient with persistent MRSA bacteremia who had previously undergone pelvic surgery and had some wires and some pins placed in the pelvis. And bacteremia had been persistent, I think, at that point for about 7 or 8 days with unknown source. They did a PET-CT, and they found increased uptake in the pelvis of those wires. And that's important information because the CT scan that they had done didn't show any abnormalities there. And based on this, you can fairly assume that that site is infected and is going to persist as a nidus for reinfection in the future. There may be nothing surgically that can be done about it, but you might tailor their antibiotics differently in that case. You might consider using rifampin, you might consider using a longer course, you might consider suppressive therapy, but it's going to change your management. A study group in Europe integrated PET-CT into their endocarditis algorithm and performed it in every patient who was admitted with Staph aureus bacteremia, specifically with a community-acquired disease. And of those 150 patients that they reported, they found sites of infection that they were not expecting in around 40%. Just under half of those were patients with musculoskeletal infections, joint infections, osteomyelitis. Around 20% were pulmonary infections, and the rest were a mixture between the two. But the survival rate in the population that underwent PET-CT imaging versus the control who just underwent usual care was much better. So we all know that PET-CTs are expensive, and so There is also there is also a group of people who are trying to get, PET CT more accepted for Staph aureus bacteremia. And this is a recent article in Clinical Infectious Diseases that came out this year. But they purport that the number needed to test to reduce or to prevent death with a PET CT in Staph aureus bacteremia is around 4 to 8. And number needed to prevent relapse is around 13. So those are pretty low numbers compared to the number needed to test to reduce or change antimicrobial therapy with a TEE, which is around 200. So the hope is that even though it's an expensive test, it can help prevent recurrences and relapses and readmissions, which is invariably more expensive. Okay. And this is also important. The new Duke guidelines include PET activity in a valve or any prosthetic material as a major imaging criteria in endocarditis in the 2023 updated guidelines. And so it's being used in many places. It's entering into guidelines, which is hopefully we'll see it enter into approval and insurance coverage. Risk factor analysis is great because it's cheap. It's free, it's cheap, it's easy, it's fast. You take patients' risk factors, put it into a calculator, and it tells you what you should do. And that's always nice. But it's not great because it doesn't make a diagnosis. If you take a patient's risk factors and mix them all together and come out with an answer, it's still giving you another risk. It's not giving you an actual diagnosis, but they can be helpful in determining who needs to undergo further workup and who doesn't. This is the Versta score, which was developed, first reported in 2016. And the Versta cohort were a group of about 2,000 patients in France with Staph aureus bacteremia. But it's been validated a few times, most recently in 2021. And the use is in identifying patients who should be evaluated further for endocarditis. So in most cases of use of the Versta scale, you're trying to decide if I should push for this patient undergoing transesophageal echocardiogram. The criteria involve risk factors for complicated disease, and it's spread across multiple points. The highest risk is patients who have, already evidence of embolic disease like peripheral or cerebral emboli, where you can most of the time safely assume that they have an endovascular infection, down to the lowest points, which are patients who are presenting with shock or CRP, which are indications that your patient's very sick, but might not be indications that there is endovascular infection. But using your patient's risk factors, they have 3 points or greater, then you would proceed further with evaluation. And this score is great to identify patients who are very low risk. If you have a Versta score less than 3, based on the data that's out there, which is not a lot of patients, the probability of endocarditis is less than 1%. But it's not very good at categorizing all those patients that are going to fit above Versta score 3. It doesn't take a lot. If your patient was bacteremic for 48 hours and they have pre-existing native valve disease, they're well above that 3-point cutoff. Or if it's community-acquired disease and they have pre-existing native valve disease, they're well above that point cutoff. So you're going to rule out that a few patients require an echocardiography, but you're still going to end up with a lot of patients that need to go forward. And so this score might help you in sort of the lowest of the lowest risk. So what would a futuristic Staph aureus bacteremia treatment algorithm look like? And this algorithm was published this year by a group in Duke who do a lot of work with Staph aureus bacteremia. And it includes the things that we just discussed. So first, you need to confirm the diagnosis of Staph aureus bacteremia, and that's just having one blood culture that's positive with Staph aureus. Second, you need to perform your thorough history and physical exam and look for those obvious sites of metastatic infection. Your patient who has a swollen knee joint or has new back pain or is having trouble seeing. After that, you risk stratify. And you're stratifying based on predisposing host factors, like the patient who has a prosthetic hip or a prosthetic valve. Features of their bacteremia, how long it was present, did they acquire it from the community, and was there a delay in treatment? And then their course of bacteremia, or do they have persistent fever? Do they already have signs of metastatic infection? And using those features categorized as low risk or high risk. There's no moderate risk because that always confuses everybody. Patients who are at low risk, who have similar criteria to what we already consider as uncomplicated disease, end up with a final diagnosis of Staph aureus bacteremia without metastatic infection. Patients who are at high risk are the ones who will target for extra diagnostic workup, and that might include PET, that might include transesophageal echocardiogram, or imaging elsewhere. If you find a metastatic site, then they have Staph aureus bacteremia with metastatic infection. And so the terminology that we use might additionally change. And then once you have your diagnosis, then you move on to an individualized treatment plan. So the future questions that we have are, what is individualized treatment? Staph aureus bacteremia would commonly fall into 2-week treatment, 4-week treatment, 6-week treatment, or above. But there might be ways to further individualize that treatment course. It could be with biomarkers. It could be with imaging as you're treating. But hopefully, we'll eventually be able to find ways to really individualize treatment courses. A big question is, can we really use PET-CT to rule out complicated disease in very high-risk patients? If your PET-CT comes back negative, are you going to feel better? If you don't, then it might not be the best test. The expense might not be worth it. And then the last future question is, we know that MRSA bacteremia is a risk factor for recurrence in the future, more so than MSSA bacteremia. And what agents are the best to treat that? There's a few more future questions, but I think these are the ones that we'll hopefully be able to answer sooner rather than later.